Episode 184, Cytopathologist and FNA Specialist. I'm your host, Dr. Justin Trost-Clair, and today we're Dr. Celina Nadelman's perspective.
Award-winning podcast host and best-selling author, Dr. Justin Trost-Clair, as we go behind the curtain and talk to doctors and experts about their specialty, marketing, and home life balance. Let's hear a doctor's perspective.
Hey, welcome back to the show. Today is fun because it's one of those interviews where you're not exactly sure where it's gonna go when you book the person, and then you learn about a whole new field of medicine that you kind of know about, but not really. And then you find out there's all these complex layers involved with it. And so that's this one. She's a pathologist, but really she's a cytopathologist. She does fine needle aspirations, and she has a private practice, which apparently was super rare. There's maybe like a dozen in the entire nation. So I hope this will be a fun episode while you drive, while you work out, whatever it is that you're doing. As always, if you go to adoctorsperspective.net/all links, you can get everything you need from the multiple series that we've done, like on acupuncture, financial, podiatry, best episodes of each year, etc. And if you'd be so kind to buy some swag or even tip me a cup of coffee, that goes a long way to kind of just feel the love, keep making these episodes, and I really appreciate you listening, of course, and writing these 5-star reviews, which I don't have enough of. So if you find it in your heart to do it, go for it. But look, the transcript and all the show notes can be found at adoctorsperspective.net/184. Let's go hashtag behind the curtain.
Live from Beverly Hills in Louisiana, today on the show, we have got a unique specialty that I had actually never really heard of, and there's a good chance that you don't either. So she graduated from the USC Kirk School of Medicine. All right, she lived in Italy for 3 years. She was an art student. Can you believe that? And studied it for like 3 years, and then we'll figure out what happened there because that's a completely different ball of wax, if you will. But her expertise is fine needle aspiration. It's called FNA. It's a whole thing. So it's going to be fun to dive into what this means. I don't want to jump too much into it, but she wants to be a compassionate, patient-centered environment while engaging in open and immediate communication with the referring doctor and actually be there when we do the biopsy to get the most complete picture. So please, welcome to the show, Dr. Celina Nadelman.
Thank you. Thank you for having me.
Absolutely. Well, thank you for being on the show, and I hope I didn't butcher that too much in there, but what's the background? Because I thought, that's really cool, like an art and then studying and then somehow switched into medicine. So how'd that play out?
I actually started out in psychology. I went to Clark University, which was it's very, very big on studying psychology. In fact, it's the only university that Freud came to when he came to the United States and lectured at. Freud and Jung. It has a very long history of psychology. And I soon got interested in psychobio, neuroscience. And I was always interested in art. I'm a very creative, artistic person. And I took a couple of classes, and then I decided to go for my junior year abroad to Florence, Italy. And there I took Italian as well as art and art history classes. And when I came back, I realized that I could actually turn it into a double major. So I was actually a double major in psychology and studio art with a minor in biology. I fell in love with the country. I didn't really know if I wanted to go into the artistic field or into the scientific field. A lot of people find that medicine is an art and a science. So I guess it kind of melds together that I eventually did become an MD, a physician. But while I was I went back to live in Rome. I went to an Academy of Decorative and Restorative Arts. I thought that maybe I would go into that. It was a big thing, fake marbling and restoration. But in the meantime, I was still interested in neuroscience. So I was matriculated through the University of Rome, La Sapienza, and I did an internship, a research internship with 2 professors there who were doing neuroscience research on, stroke victims as well as dementia patients. And then I decided to come back and go into medical school.
Well, it really could have went either way because I'm thinking restorative art would kind of taken you on a life path with a lot of adventure and seeing amazing things. But ultimately, I guess, that could be always a retirement plan or a second career. I'm going to get back into this. Okay, so there's lots of specialties out there. You could have just been Joe Smo pathologist, but then you took it to the next level.
Well, yeah, actually, my life kind of always had like a circuitous route. Like and I tell this to even when I go and speak at like high schools or colleges, I try and impress young people that nothing is written in stone. Like I thought, all of my friends who went into medicine, they'd wanted to go to medical school since they were like in kindergarten. Well, I didn't. And they knew exactly within their first or second year what specialty they wanted to go into. And I didn't. I wanted one specialty. And then I actually went into internal medicine. I did a year of internal medicine at the VA, UCLA program, and discovered that although I liked, dealing with patients, it was not for me. It was not I didn't feel like this was my home, and did actually research in dermatology and wound healing. And then I had always liked pathology in medical school. It was taught fantastically well at USC. Pathologists were all really nice and very knowledgeable. But when I was going to medical school, the great push was to go into primary care. I mean, everybody was supposed to go into primary care, which was, internal medicine or family practice, pediatrics, gynecology, some general surgery, but no subspecialties. And I did a sub-I.
Is that what they needed back then?
Yes. Yeah. It was all primary care. And when I had done a sub-I in pathology, I enjoyed it, but everybody was like, don't go into it. There are no jobs. So after my research fellowship, after my internship, I kind of fell into pathology. I didn't really know what I wanted to do. My husband at the time had decided to go back to school. He had gone to medical school in the Soviet Union and decided to go back and get a Chinese medical degree. So he was getting his OMDs, master's in Oriental medicine. And so I had to choose a program that was in Los Angeles. And there were openings in specific areas, and one of them was pathology. And one of my mom's friends was a pathologist. He was like the chief of pathology at one of the major hospitals here in Los Angeles. He was like the president of the, College of American Pathology. He was very, very involved. And he said, why don't you just try it? I love it. It's a great career. So I went and interviewed, not expecting to get accepted, because it was kind of last minute. And I figured, and they said at the end of the interviews, they said, when can you come? I said, I'm going to just take it as a year just to learn about the profession. Because, when you learn about pathology in medical school, it's very different than how you practice as a pathologist.
Yeah, I can imagine.
So I kind of sat back and just enjoyed the learning rather than really being stressed out about it. A lot of people get stressed out about the learning. And so that first year of residency in pathology was just to introduce me to the world of pathology as a profession. Thereafter, I did a fine needle aspiration clinic. It's just part of one of the rotations in cytopathology, which is kind of cells in space. It's like what you see in pap smears or urines or fluids. And one of the things was fine needle aspirations, which is actually doing a small needle biopsy. And then you smear it on a slide and you look under the microscope and you determine what the person has. So it's the smallest amount of tissue that you can get.
It's got to be comfortable for the patient.
It's much more comfortable than having to have a surgery. I mean, so at first, when I first looked at it, I thought, what is this? Cells in space. I can't understand it. But when it clicked, I was like, wow, this is really cool. And I always liked doing procedures. During medical school, I was very good at surgery, but I didn't see myself as a surgeon because I didn't like the work-life balance. In fact, those people who did well in surgery had at the end of the year a dinner. And so if you did well, you were invited to this dinner, and I was one of the only women at the dinner, and I was sat with all the female surgeons there, and they said, so are you going into surgery? And I said, well, I kind of want to have a family. And one of them joked, like, what about surrogacy? And I was like, oh my God, this is not for me.
Come on.
No, I mean, obviously this is different now, but back
Yeah.
then, this is what, they were, anyway, there were surgeons who had many kids, but I'm just saying that, there's, surgery is a certain way, and you kind of have to devote your life to the hospital and that, and it kind of, I think having a family until you're established as a surgeon, it takes a long time, and it goes by the wayside. So I wanted to make sure that that was very important to me. I wanted to have a family, and I wanted to have something that I really enjoyed doing and waking up.
I mean, how many people don't even have that realization and then wake up 15 years later and they're like, wow, I really missed out on something and I didn't even listen to my heart during that time. And also, kudos for you to realize really fast, I don't like this whole patient interaction, managing diabetes and all these different things all the time. Like, what a great thing to figure out now versus later.
You know what? It wasn't the patient interaction per se, because I liked that part.
Mm-hmm.
It was, internal medicine, it's a different way of thinking of things. I'm a visual person, like as an artist.
Mm-hmm.
So pathology pathology is basically the study of human disease. So as a pathologist, pathologists are considered the doctor's doctor. So all the doctors come to us for the answers. You send off blood samples to the lab. We're the laboratorians. We tell you whether you have high cholesterol, or we tell you if your CBC's off, or if you have leukemia, or
you had the most stressful part. We take the biopsy, and then we're like, all right, pass the buck on to somebody else to tell me what it is.
Kind of, yes.
Like a chiropractor. Hey, we got something on MRI. I don't know what it is. Send it to the radiologist. Now it's on them. Tell me what it is so we can refer it around. It's like, that's a lot of pressure.
It is. It can be. There's a lot of learning, but it's very interesting. That I also, it's anatomic pathology is very visual. So it's all about pattern recognition. When I was in medical school, the chief of pathology used to, back then they were slide carousels. So they would put up the slides of different things, and he would intersperse like the picture of the Eiffel Tower or the Taj Mahal, Mount Fuji, and he would say, okay, where is this? And we'd say Paris or India or, Japan. He's like, yes. Because you can recognize that this is a pattern. Like, this is the Eiffel Tower, and that belongs in Paris. So anatomic pathology is very similar to that. All the things have a pattern, and from that pattern recognition, you can make a certain diagnosis.
When you see it enough, you see it.
Right, exactly. So if you don't have a good eye, then a lot of pathologists, anatomic pathologists, are artistic. They have it because they're just drawn to that, and they're drawn to that kind of.
Really, you fit right in. It's kind of like that hidden calling that you didn't even know was there. You're like, oh, where's that on the professional matchmaking?
When I was in my second year of residency, a guy came and he said, "Oh, I have a standalone fine needle aspiration clinic," and I thought, "Wow, I love that, and that's what I'm going to do." So that's what I did. I went and pursued having a private practice as a pathologist. And when I first started out, and I would go and do networking with other local clinicians in the area, they would say, "What? You're a pathologist and you have your own clinic? Like, you see patients?" Because most pathologists only thought of as like looking at parts or autopsies. So
right. So let me ask you this: pre-talk, you had mentioned there's only like 12 private practices. So I'm curious as to,
I don't know how many exactly, but about a dozen.
But definitely not enough to serve the amount of people that probably need it. So are you able to cross state lines or just have multiple licenses, or is it just like so out there to have your own clinic? I mean, do you take insurance? Is it a cash thing? Or so many questions about that. What do you think? Because it sounds like a great business idea too. Because
there aren't, but the issue is I'm in Los Angeles. And in West Los Angeles, there are at least 3 large hospitals that profess excellent care just within 10 miles.
So like Houston might be one of those places then.
I'm just saying, like Los Angeles, there's, St. John's, there's UCLA, and there's Cedars, all within 10 miles of my clinic.
Ah, okay.
I'm competing with them, and they're competing with me. People can go and have a fine needle aspiration biopsy by anybody who it has an MD by their name.
Oh.
whether they get diagnostic material, that's a different story. So when I first started out, I worked at the VA, I ran the FNA clinic there, but I also was a staff pathologist. And so we would get FNA smears from endocrinologists, from ENTs, from surgeons, and most of them were barely readable. We would try our hardest because the clinicians would get upset. Like, what? You don't have enough material, or you can't read it? Or when I first started out in private practice, I would have an endocrinologist send me their biopsies. Like, they would do the biopsy. They would see the patient, they would do the biopsy, and then they would send me their slides. And I would have to look through 40 bloody slides to get like a couple of cells. And that would take a lot of time.
Yeah.
They don't realize if you're not a cytopathologist or even a pathologist, most other doctors don't quite understand or realize what it takes to get a good sample. They think, oh, if I have a syringe and I pull my syringe and I get blood, that means it's going to be a good sample. But in actuality, blood is obscuring, especially for thyroid biopsies. I want to get as little blood as possible with as much cells and make sure that it's fixed immediately and that the smear is correct. And the other thing that they cannot do, which is, I can't do surgery. I learned it, in medical school, but I'm a pathologist and I read these all the time. I have a microscope right in the same room with the patient. So when I do the biopsy, I smear it and I stain one of the slides immediately. The rest I fix and I look at it right there. The patient's on the table and I'm looking at the slide and I can say, oh, I need more material because later on I need to make a better diagnosis. Or I need more material because I know I need to send it for another type of test. I had a patient once, he was referred to me because he had a rapidly growing thyroid mass. And of course, he was of that age, he was over 70, and clinicians immediately think it's the worst kind of cancer. Most thyroid cancers are not bad. Most people do not die of them. But there's one type that's usually in the elderly, and it grows like literally overnight, and it kills people within a year. Like there's nothing to be done. It's called anaplastic thyroid cancer, and so the patient was immediately sent to me. And when I looked at it, it's called on-site evaluation of the slide, or ROSE, rapid on-site evaluation. I saw that it wasn't made up of thyroid cells, but rather made up of lymphocytes, the same kind of cells that are seen in your lymph nodes or in the bloodstream. And so it dawned on me, I thought maybe this could be, there are inflammatory situations in the thyroid, but this looks more like it could be a lymphoma. So at that point, I took more material, I went back, and I put it in this special medium that could be sent for another test for flow cytometry, which is to rule in or rule out lymphoma. And lo and behold, the patient had lymphoma and not anaplastic thyroid cancer. So the patient, if he had gone to either a radiologist or an endocrinologist or an ENT, that sample would have been sent to the lab in, let's say, a hospital or Quest or LabCorp. They would have said atypical cells or lymphocytes present, go back.
So they said it anyway.
They would have not been able to make a diagnosis immediately, and the patient would have to go back for a second biopsy, or they could have missed it altogether. But this way, it's a one-stop shop. The patient is able to go only once, get a biopsy only once, get the answer, and the patient never had to have surgery. The patient went directly for chemotherapy and was fine. Yes. So in that way, as a pathologist, cytopathologist, I am able to look at the material immediately, in real life,
right,
to ensure not only that I have a diagnostic sample so that the patient doesn't have to come back, because oftentimes it's missed, there's too much blood, or if I do need to send the sample for something else. Like I could send it for molecular studies, I could send it for flow cytometry, I can send it from, let's say, microbiology. Let's say I look at it and someone comes in with a lymph node, I do a biopsy of a swollen lymph node, and it looks like there's an infection. I can send it for culture. I've diagnosed TB twice. When patients have come to me, the doctor said, oh, I think it's a lymphoma, and actually they had TB.
That's wild. So I guess would one of the take-home messages for today be, if you're a doctor that can actually do these things, obviously I'm a chiropractor and whatnot, so obviously I don't do that, but the audience is bigger than me. When we're looking for a pathologist, can we request a cytopathologist versus just a regular pathologist? So you just get who you get.
Generally, out there. Let's say you find a lump on your body. You go to your primary care doctor. He's like, okay, well, I know this great, let's say, endocrinologist. Let's say they find a thyroid nodule. The endocrinologist may or may not have had experience in doing thyroid ultrasounds, most likely had, and doing FNAs. The problem is they may be a brilliant endocrinologist, like, don't ask me how to manage your diabetes, or, I don't know how to, like, deal with hormones. I know of it, but I don't know how to, like, treat you. And they try and do the biopsy themselves because your primary care physician knows them as a person and thinks they're a smart person, but the fact that they can't look at the microscope themselves and they don't know what really it entails to make a perfect smear, it makes my job harder if I'm on the receiving end, in the laboratory. I mean, I've been actually an expert witness for cases, that have gone to court.
Right.
Patients have sued and, sued the pathologist, and it's not necessarily the pathologist's fault. It's the pathologist doesn't get, like I said,
a good sample. It's too much blood or whatever.
Well, sometimes, the person who's performing the biopsy, I can teach anybody to perform a biopsy. You just stick a needle into something. I mean, that's all it is. It really.
Right.
The skill is being able to get diagnostic material. And the only way that aside from the feel and having, like, expertise, like knowing how to do a biopsy well, is also being able to look at it and make sure that you've done a good sample and how to fix it well.
Could they do a CE you've got to take continuing education. Are they able to do some sort of biopsy refresher course?
Well, they don't know they're not pathologists. They don't look under the microscope. Let's say endocrinologists, they look at thyroid samples. Sure, they do that in their fellowship. They do it. There's some endocrinologists that profess that they're just as good as any pathologist. But this is not what they do. I mean, this is
so their ego probably wouldn't allow them to. Some of them.
I'm just saying, and part of, let's say, ENT. Like when I was at UCLA and training at UCLA, we used to do conferences, pathology, otolaryngology conferences, and they learned how to recognize what certain things look like. But it's like a tiny bit of their education, most of their education and most of their training, and then years later on, based on their specialty.
Mm-hmm.
And as you go on, I mean, I'm not doing general pathology. I mean, yes, I can go back and probably read GI, biopsies, but that's not my specialty anymore.
Right.
It's there, but now I'm doing cytology mostly, and so that's my expertise. Like I see a gajillion thyroids. I do a lot of thyroid FNAs. I do a lot of head and neck tumors. I know this is like my bread and butter, and so you get better and better at it. And it's not just being able to know how to make the sample and how to read the sample at the side, the microscope, using the microscope in a certain way and knowing that. It's everything else. It's I'm a hybrid between the clinician, like the surgeon and the internist and the endocrinologist, and a pathologist. So my background in internal medicine has helped me in being able to be with patients and look at them as holistic, their problems in a holistic way. I have the advantage over my pathology colleagues in that I get to see the patients and I actually get to feel them. You know what I mean? When you're in the laboratory and you're just receiving the slides, you may get on a requisition form like 35-year-old, Caucasian male with a 2-year history of a 1 centimeter thyroid nodule. And that's all.
Right.
But when I see patients, I get to talk to them and I get a focused history and physical. I ask how long it's been there. Does it bother them? Are they hoarse? Do they have a family history? Oh yeah, my mom had goiter and my late cousin had died of papillary carcinoma of the thyroid, or yes, I survived Chernobyl. There are things that
those mild details. Like, what am I looking at, and why am I looking at this?
Yeah, I mean, I've had interesting cases. I had a man who had a thyroid nodule for many, many years, and in his remote history, 20 years prior, he had kidney cancer, renal cell carcinoma. So when I did the biopsy, it looked strange. And so there's a nomenclature that cytopathology and pathologists use. And so part of that nomenclature was, atypia. And so I sent it out and it came back, and I sent it out for molecular studies. And the molecular studies came back that it was metastatic kidney cancer.
Wow.
And the referring doctor couldn't believe it. So that nodule's been there for so long. I can't imagine it's not goiter or thyroid nodule. And so he asked me to do it again. So I did the biopsy again. And this time I took more material so I could actually stain the material in a certain way to prove whether it's thyroid origin or whether it's kidney origin. And it turned out again to be kidney.
It's in my head. It goes, the fact that there's that many tests and that many stains that you can do that is pretty cool to me. That's really cool. Obviously there's different materials in.
And things are getting much more like granular as medicine is going forward. We're able to diagnose things on smaller and smaller samples, which is why as a cytopathologist, it's very exciting. I can do fine needle aspirations, and it's minimally harmful to the patient. It's a tiny needle. It's like smaller than the kind that you use to draw blood with. It's like between that and a Botox needle. And instead of going in the old days, they used to cut everybody out. They cut out things. And we're finding things that are smaller and smaller because our imaging modalities are better. Our ultrasounds are getting better. People are getting MRIs. It's getting much clearer. And the other thing is we're able to do things with small samples and small cell samples because we have like molecular techniques. These are like more and more molecular techniques. Like one of the things that I use quite often is if I can't tell, sometimes there's diagnosing something that's benign is easy. Diagnosing something that's cancer is easy. The things that are in between is what makes me sweat. Makes me like I sit there and I ponder it forever and ever. And I'm lucky that in, let's say, thyroid, I could send it off for molecular studies. And now they're looking at all the different permutations and chromosomal aberrations, genetic problems that could lead to cancer. Yes. And it's expanded. I mean, it's constantly expanding.
It makes you wonder what we were doing 30 years ago.
It used to be that people would come, let's say thyroid cancer. You'd have to have a big, huge goiter. And they would say, oh, I see that. Let's cut it out. And the problem is that most of them are benign.
And the treatment's probably better now, too. If you can get to that granular level of what exactly it is, you can probably tailor the treatment to exactly what that is instead of guessing and hoping.
Things are going that way. It's called immune therapy, like in lung cancer. I mean, I'm sure you've heard of things like Keytruda and things that are advertised on TV. Those are cancer diagnostics, and which is my bread and butter, but therapeutics are getting better and better and less harmful to the entire body. So, they're looking at ways to kind of, instead of destroying everything, like with just a big shotgun, getting a sharpshooter in there.
Well, we had a couple patients this week who were talking about their spouses and they were doing chemo and they had the chemo fog afterwards. They're like, my husband was completely useless. Like, couldn't remember anything. And I was like, well, I heard it fades over time, but they're like, yeah, but during the time frame it was bad. But switching gears a little. So if you're doing private practice, what are you doing to market? Like maybe you don't have to do it as much now. You got a name for yourself, but
I still have
when you were kind of starting out, you still have to do it. What are you doing? What's working?
I don't know.
Cookies to the doctor?
You know what? The best way, I've tried all different kinds of ways. At first, going doctor to doctor. I mean, I do have a reputation. I'd say most ENTs and a lot of internists and endocrinologists know me, know of me.
You don't need everyone to refer to you, but you do need a certain amount to keep your schedule full.
Yeah, I'd like more.
Yeah.
I'd say most of a lot, because I'm in this area, I'd say all of the concierge doctors know me and refer to me. So I see,
that's huge.
I also work for the County of Los Angeles in South Central Los Angeles for the underserved. I work at Martin Luther King Jr. Outpatient Clinic doing exactly this. I was recruited by the chief of endocrinology. And so I see all walks of life. And some of those doctors also have private practices and they refer me patients. When I'm training my assistant is like, everybody gets anxious. Everybody comes in thinking that they have cancer when most of the time they don't. But everybody has that thought. And so everybody has to be like sensitive to it. And people react differently, and you have to be sensitive to it. So how do I market? The best method is meeting the doctors up front. I mean, going and introducing myself. I used to have someone who used to market for me. She was much more organized than I was. She at all these Excel spreadsheets.
It's so
I
helpful.
I did direct mail. It's very expensive. I don't know how much. Although some doctors were like, oh yeah, I remember your postcard. I'm trying to fax. Now I'm trying to get into like social media and Instagram. I don't know how much that's helping. Yeah, I don't know.
Yeah, you got a unique challenge, I would say.
Part of the challenge is educating other doctors, referring doctors, that someone like me exists, because they just I've never heard of someone like me. And the other challenge, and that's the other thing that I want to reach out to the public, is I want to change the paradigm. For now, you have to be referred to me by a doctor.
Oh.
There's a prescription, right? You can't walk. I'm like a radiologist. You can't walk into a radiology suite and say, like, hey, I want an x-ray. You have to get a prescription or a referral. Just like you can't walk into pharmacy and say, I want an antibiotic. You need to have a prescription. But I want to change the paradigm, the kind of paradigm that's being changed already in the past 30 years. It used to be you never saw advertising for drugs in magazines or on TV, right? Mm-hmm. But now, because you can't go in and say, I want Keytruda, you have to go to your doctor, and the doctor has to write you a prescription. And that's what I want to do. I want to reach the public, because I feel that nowadays the public's much more skeptical and much more in control of their own health care and their health care choices. Before, I think medicine was much more paternalistic, and now people are much more questioning, and I feel that they can have access to superior medicine, and to someone like me, they just need to know about me and be able to ask their doctor. So I have gotten people from the internet as well.
You know, I recorded an interview tomorrow with the author who describes sort of the downfall and the reason why everything is so expensive with healthcare in America. And he mentioned things like what you just said about direct access and some of these prescriptions that we have to have, and just kind of there's lots of little rabbit holes that, that interview might take, because you look at it and you're like, we should be able to go and get an MRI, especially if we're willing to pay for it out of pocket. But you still have to get that prescription. And
because people don't understand. I think,
yeah.
I mean, something as simple as I have a nodule. I know I have a nodule. I think it needs to be biopsied. And if your doctor's saying, oh, you're going to go to my friend, the endocrinologist, to biopsy it, you can say, he's already referring you for, it's like saying, you need to go and get a mammogram, okay? I'm already writing you a prescription to get a mammogram, but you can choose with that prescription where you go and get your mammogram. You don't have to go in the same office building as your doctor. You can go to wherever.
And people don't realize that, I don't think, either.
A lot of people here in Los Angeles, they choose where they want to go and get their mammograms. They're no longer going just next door. They're like, I want to go to an academic center. I want to go to UCLA for my mammogram, or I want to go to Cedars. I want to go to Tower. Yes, they take their prescription, or the prescription gets actually faxed to that radiology center or mammogram center, and they choose. The patients choose. So that's what I want eventually. I want patients to be able to say, hey, this is a better way, and I want to choose that way, rather than just depending on where their doctor happens to be sending them.
It's kind of fun to be enlightened by this. Every profession, as a chiropractor, of course, we're like, hey, the case management actually recommends us and PT and doesn't recommend these drugs. Actually, it's really a better physical modality is the best option, yada, yada, yada. And then, of course, when you've been doing it for a long time, you're like, headaches, that's like my bread and butter. We should be one of the first choices that you pick. Oh, not that person, but me, And like every profession, it seems to have that, like a podiatrist. Wait, send them to me. Don't send them to the ortho. And like, it's fun to see that, like, even you have to deal with some of that stuff as well in a different aspect, but it's still educating so much.
I think because there's so much overlap in your field for a very, very long time, a lot of doctors I'm still meeting doctors, even on the West Side, who are like, what? I've never heard of that. I've never heard of a pathologist actually seeing patients and doing biopsies and, also having a laboratory, under one roof, like one-stop shop.
Well, here's my card. Here's my script pad.
No, of course. I mean, that's just part of it. But I want to be able to reach a broader audience. I want to be able to give good, excellent, superior care. I believe that everybody deserves it, regardless of where they are.
And do you have staff?
I do. It's very small.
Okay. Do they handle more scheduling or like back end stuff?
Everything. They're jack of all trades.
Yes. Okay. maximize their potential.
Yes, yes. I have a sonographer, I have an ultrasound tech who helps me with that, because usually in a lot of settings, let's say people who do fine needle aspirations, they have a nurse, and let's say a radiologist is doing the biopsy, and they usually have a sonographer with them, even though they're a radiologist, and then they have someone else smear the slides. I'm the pathologist. I'm the laboratory professional. I want to smear my own slides. I have control over that. I want to have good, clear slides, because I know I need to read them later on, and I need to make a diagnosis out of them.
Indeed. Well, let's switch gears. I want to respect your time and the audience and everything. One of my favorite questions is we talk about relationships, and you have a spouse, and we always want to keep the love alive and not end up divorced and have a happy marriage. So do you have any tips or advice on what we can do for that?
I met my husband right before I started medical school. So it's been 28 years, and we've been married for 24. We have 3 children.
And this is the one that we did the Chinese medicine degree earlier. Okay. Wow.
He's a hospital administrator. He didn't really pursue acupuncture and herbology. He does it kind of on the side, but doesn't really do that.
That's kind of a big deal, too. You can't just get that job. You got to earn that one.
Yeah. He's been working for a while. You know what? I think you can't be on cruise control, I think a lot of men, once they get married, they kind of get into cruise control. And I think women are kind of, the prodders a little bit more. But, we're real partners, I think. We engage each other in partnership. And, occasionally when there are issues, we go into, group family therapy. When I want to hammer something out, I feel like I need a third person to present it so it doesn't sound like Lucy of the Peanuts, wah, 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 wah,
Yeah, it's a safe environment to really air out the grievances sometimes.
Well, I just think that women are a lot of times seen as, when we have complaints, we're seen as nagging, and it doesn't. You hit a wall with that. You can't get anywhere if someone just pushes that aside. Something that's bothersome. We've gone through a lot together. I think we respect each other, and we want to strive to be better for each other.
2 strong professionals. 2 careers that actually take up a lot of time. You had a couple kids, right? You said
3.
So it's always the sexist question. So how did that play out where the roles of child rearing typically fall on the women, especially a few years back there, and you had a demanding job?
Oh, let me tell you, that's one of the reasons why, that's like a...
What do you do? How does that work? How do you shuffle all of these things?
Women got the short end of the stick, at least in my generation, okay? My generation. Gen X.
You still got to do 95% of the child care and go to work.
Gen X, we had to become professionals. Like, my mom was like, you have to become a professional.
What if something happens?
Yeah, it was like all of my friends, all of my friends that I grew up with are professionals. Half of them are doctors. I have a lawyer, a businesswoman. They all have masters, at least, if not doctorates. These are friends I grew up with from elementary school and high school. For me, I always knew I wanted to have family and children. That was first and foremost. And that my career was always secondary in my head. You can't really go through medical school and residency without some sort of sacrifice. And I did have help. I mean, we had to pay for child care. And I went into a profession knowing that I didn't want to spend all my life doing, my work, and that I wanted to be present, and which is one of the reasons why I work part-time. I carved this out. Like, my way of working, I may not earn as much as my colleagues. I earn like maybe a half what they do. But that's because I want to be flexible, have a flexible schedule. I crafted it this way. It was very, very important. And
life by design.
Life by design. My kids don't get to go to Europe every summer and stay in hotels, and we stay in Airbnbs, instead. But we still get to experience life. I think it's really important. I think, travel and culture. I grew up traveling. Half of my family lives in Europe. I believe in experiencing life, and I never skimped on that. These are the choices that I had to make, and I'm actually very happy about them.
Yeah. I mean, I love that, because I'm with you. Even as a guy, I don't want to spend all my time at work. I want to spend time with my kid. I want to not have to put in the hour, 50 hours, 60, 70 hours a week, because I was like, what's going to happen? Like, she's only going to be this age at one time. And pretty soon,
Yes.
there'll be teenagers that not even want to deal with me. And then, cool.
Let me tell you,
I got other things I want to do too.
Yeah, two of my oldest kids are actually moving out in the fall. They're both, my one is going into a master's program in New York, and the other one is starting college. And so and then my youngest one is still in middle school. But, I can't believe it. They've been like a nuclear family for so long, and now all of a sudden they're leaving the nest. It's going to be kind of a shocker all at once. But it was really important for me to be doing something that I truly loved. I love what I do. And I think because of it, and just because of all the things together, like I'm good at what I do, I think I'm the best. I'm one of the best, probably, at least in California, of this, what I do.
That's great. That's what's cool is when you're good, and then there's nobody that really can compete. It's just like, I'm not being cocky. It's just we have a small playing field, and I've worked so hard.
Yeah, but it's also an important, I think, example to have to lead for your children, to know that, so that they see a parent who feels their self-worth in the world, that you're giving back in some way, and also
you can be happy
that
at
you're
a job.
happy at a job. Yes, because
imagine that. So many people don't even have the luxury of being happy at a job, much less. Do you have a webpage or anything for people to contact you?
My webpage is www.drnadelman.com. So DRNADELMAN.com. And my Instagram is at Dr. Cancer Answer. DR Cancer Answer.
I just want to thank you so much for being on the show and enlightening us on what you do, because that is definitely a profession that needs more. Like you said, it needs to be highlighted. It needs to be promoted. I hope that we see that change over the next 5 to 10 years. And of course, if you can get some more connections from this, that's a great thing too. But check out our Instagram. I'm pretty sure she's going to have some amazing stuff there. I didn't get to check it out yet. But thank you so much again for being on the show.
Thank you. Thank you so much for having me. Have a good night.
Another great interview has ended. While you're on your phone, click that review button. Write up a nice review for me. 5 stars if you could. As everyone says in the industry, it'll help other people to find us when we have enough rankings. Not to mention, I'll mention you and your review on an upcoming episode. If you're looking for one sheets, if you're looking for all the books that people have recommended, you can just go to doctorsperspective.net/guide. And that's going to give you everything you need to know. The top episodes of 2017 and 2018, the podiatry series, dentist, acupuncture series, holiday 2017, financial series, how to write a review, how to support the show like buying a cup of coffee, getting swag like t-shirts, the Today's Choices Tomorrow's Health book, that's the blueprints for better health, exercise, picking food correctly, and financial. And then of course, bundle packs, which can get you the no needle acupuncture book for 40 common conditions, including the electric acupuncture pin at a great deal. Page has some of the products that I like. It's affiliate style, so if you buy something from them, I get a piece of that. Just like on the show notes pages, if you buy a book from clicking that link, I get a small piece of that as well. So I really appreciate that. Things like Screencast-O-Matic, Pure VPN, Missing Letter, JLab speakers, Prolone, Edge, or Hawk grips. The trilingual coloring book is now 5 languages: English, Spanish, Chinese, German, and French. So pick one up for your own kids, your nieces and nephews, and also for your office, so these kids have something to do. Again, that all-encompassing one link is adoctorsperspective.net/guide, GUIDE. Once again, if you do need any coaching on how to improve some of your blood work, drop weight, and the Prolone diet, fast mimicking diet, 5-day plan, let me know. As well as if you just need some coaching, whether it's health, whether it's marketing, whether you need some practice growth, etc. Reach out. Facebook, Justin Trosclair, MCC. Of course, at adoctorsperspective.net on the top right, you got all the social media icons that you can imagine. Click your favorite and reach out. Thank you so much for tuning in. Please tell a friend, pass it along. You can go to .net/listen. It's just that easy. It'll open up right in your app. And don't forget, I appreciate you. Listen, critically think, and integrate. See you on the mini-sodes. Hope you're enjoying those. I'm definitely having fun summarizing these podcasts in less than 10 minutes for you. You get the nuggets without having to waste your time. Have a great week.